Hi, my name is Kenya Yancey. I'm a SRNA student, and my project is on improving safety during C-section deliveries and standardized SBAR protocols between L&D RNs and anesthesia providers. This is actually my capstone project, so let's get into it. Communication failures are still hurting mothers and babies today. 23% of anesthesia malpractice claims are due to miscommunication errors. C-section deliveries require seamless coordination between L&D nurses and anesthesia, as we know. Lack of standardized terminology between the RNs communicating to the anesthesia, or it could be the doctors communicating to the RNs about what's going on between the vocab terminologies between urgent, stat, and causes confusion and delays. And we'll get into what the standards for maybe urgent are for this project and what stat is for this project. When every second counts, assumptions and miscommunication puts lives at risk. I've witnessed firsthand how unclear urgency terms or missing patient background leads to dangerous delays in care. It's time we fix this with a simple, unified tool. We have the clinical expertise, we have the technology. What we're missing is a shared language and consistent urgency scale. This isn't just a safety issue, it's a leadership opportunity to model excellence in crisis responses. Not all emergencies are equal, but they must be clear. So this is my table on the levels of stat, emergent, urgent, the definition. So stat, the immediate threat to life of the mother and fetus. I feel like every hospital should have a standard of what stat, emergent, and urgent is to that hospital, or everyone should have a universal protocol. The time frame should be less than 5 minutes. Examples: cork prolapse, uterine rupture. Emergent, high risk but not yet critical, deterioration expected. That can be a 10 to 30 minute time frame. Category 3, fetal tracing. Urgent, no immediate threat, but early delivery recommended. 30 to 60 minutes, what you start from when the surgery will most likely start. Arrest of dilation with the D cells. So that's a good example. So like urgent, as an anesthesia, we have time to still put in a spinal. So that's why it's important to know, like with stat, we don't have time to put in a spinal. We're gonna use general for that patient. So what stat to one nurse might be urgent to another, emergent to another. This variability costs time and outcomes. Standardizing our language across the department aligns our actions and expectations. We're not just clarifying definitions, we're clarifying responsibilities. When everyone interrupts the same urgent level in the same way, we act faster and smarter. So now we're going to SBAR. It's a structured communication, and SBAR equals safe for patients. This SBAR protocol doesn't just clarify, it empowers nurses and streamlines anesthesia responses. It's how we avoid the gaps in the Swiss cheese of failure. Picture this: the nurse doesn't hesitate. She calls anesthesia, and within 30 seconds, the provider has all the relevant information. No need for follow-ups or guesswork. That's precision. That's safety. So we're going to get into the SBAR kind of setup of example of how the nurse can call the anesthesia. So they can call the anesthesia provider and say, "Hi, this is Zaire, L&D nurse. We have a situation, stat, emergent, urgent, C-section, and the reason for it. The OR status, is it ready? Is it in prep?" Then we go into the background of the patient. What's the patient's age, their gravida number, epidural status, is it placed, is it working, is it not placed? Then history, obesity, preeclampsia, gestational diabetes, allergies. And then we can go into assessment. The patient's blood pressure, the heart rate, the O2 sats right now, the fetal heart rate, is the fetal heart rate bradycardia? Is it late decels? The cervix, are they complete? Then we can go into recommendations. Did the doctor maybe say a recommendation to the nurse to pass on? Did they want to extend the epidural, initiate general spinal place? And then we can affirm the ETA and prepare. Do I want the nurse can ask, do you want an airway cart ready? Do you want any medications for me to get ready for you, etc. From whiteboard to workflow, bake it stick. So now we have to go into how we're going to get the staff to make it stick. So staff education and urgency definitions in SBAR language. I would like to have a laminated SBAR cue card at every L&D station. That would be nice. So it's just something that's right there so they won't forget to go by that SBAR. Run quarterly interprofessional SBAR stimulation drills. Embed, how we're going to embed it. We're going to embed SBARs into the EHR templates, and we're going to require readbacks from our staff, so we can make this actually help the patient. So now we're going to wrap up this presentation. A preventable delay is a preventable harm. C-section rates are rising, especially unplanned. Patient safety expectations are higher than ever. Miscommunications are no longer acceptable in 2025. This isn't just a communication tool, it's a safety mechanism. It's how we protect our patients and our providers. I'm asking for your support to implement this as a departmental standard. Let's move from this variability to reliability, one SBAR at a time. Let's be the hospital that other departments look to and say that's how it should be done. We owe that to every mother, every baby, and every provider in that OR. Remember, when it comes to L&D, everything we do is time sensitive. Thank you for your time. Your support makes patient safety stronger. Questions are welcome. And these are my references. I actually wanted to go into why I chose this project. Actually, at the clinical site I'm at, they were actually having an issue with the nurses telling them something was urgent or something was stat, and the whole anesthesia team goes up the stairs thinking it's something that's going to be a general, difficult airway, and it's actually a situation where they can actually have time to put in a spinal. So it takes away the resources from downstairs and puts anesthesia in a bad situation downstairs when it wasn't really anything stat. It was just the language being used by the RNs. So the anesthesia was trying to figure out, was it the doctors telling the nurses this? Were the nurses just using the wrong terminology? And I just wanted to come up with a standard protocol, not just for this hospital, but that most hospitals can use so everybody has the right definitions of urgent, emergent, and stat, and a standard protocol for everyone to use for SBAR, so that the anesthesia provider has all the information they need to have a safe delivery for the patient and the baby. So stay tuned for my capstone project. Bye.